Well, good morning, everybody. I'm Susie Mullens, and I'm going to be your host for today. I am the program coordinator for the West Virginia Collegiate Recovery Network, and we welcome you to the first West Virginia Collegiate Recovery Conference. We have a wonderful schedule today and a wonderful set of speakers. I think everybody will really get a lot out of the presentations today and hopefully get a lot of good information about collegiate recovery and how we can grow it in West Virginia. So we are going to start this morning with our keynote address called Making the Case for Collegiate Recovery. And our panelists for this session are Amy Saunders, Elizabeth Coffey, Rachel Thaxton, Tim Rabolt, Sierra Castedo de Martell, and Allison Smith. So welcome everybody, and we'll pass it off to Amy.
All again for having me. I'm Amy Saunders with Marshall's Center of Excellence for Recovery, and my background's really been in public and mental health on college campuses for over 20 years. I've had the great privilege of working at Marshall with many folks on this call and around the kind of state to work on prevention and treatment efforts and recovery efforts. And so I'm very excited to be here. I'm going to just share a little bit about the landscape and some of the information and data related to students and substance misuse in higher education in West Virginia. I think that's really important for us to kind of think about as we look at some of this information that we're going to hear today about collegiate recovery and why it's so important. Sorry, I'm trying to hit from the beginning to start this. Here we go. I think it's really important for us to start off to really say that anybody can develop a substance use issue or a mental health issue and develop one of those conditions. I think it's really important for us to think about that. But we now know a lot more than we did even 5 years, 10 years ago. And we know that there are certain factors that can really increase the likelihood that somebody may develop a substance use or a mental health, behavioral health kind of condition. And so I think it's really important for us to think about. And we know that risk factors are really anything that can increase the likelihood of that, and protective factors are really things that we need to be thinking about increasing more on campuses and making sure that we have those available to decrease the likelihood of folks developing some of these issues later in life. This is something that I really like to share. This is the socio-ecological model. It's a framework to really kind of think about risk and protective factors and how they can affect somebody over their lifetime. We know risk and protective factors can be fixed, and things like genetics, or they can be things that can vary over a person's lifetime, like their income. We also know that adverse childhood experiences, historical trauma, multi-generational poverty, some of those issues can also affect an individuals. So it's important for us to think about this lens as we think about some of the supports and things that are needed. We also know that relationships, family members, peers can be important. We know that society, your community where you live and work is really important and can lead to some of those issues. And then these larger social factors, things that we call the social determinants of health, things like discrimination and racism and laws that limit access to treatment or parity and coverage for services can also play important pieces in this picture. If we want to look at risk and protective factors, there's been a lot of research that's been done in this area, and we know that individuals who get education regarding harms associated with substance misuse are really important. We know that parental involvement, peer disapproval is important in terms of protective factors and kind of increasing some of those things. We know in community engagement and connectedness to peers and peer support, but also to campuses, to mentors, to teachers, to faculty. That's really important in terms of providing protective factors to students who may have substance misuse or, who may be in recovery as well. Involvement in youth leadership programs is especially important, and making sure that those are kind of youth-led or health promotion groups. We know that that's really important and critical too. We know risk factors that can be when there's more tolerant kind of attitudes or ideas about substance use among peers or parents, even among campuses. Those can have be risk factors for students that we need to be paying attention to. We know there's a large link between educational attainment and students dropping out and GPA and prescription drug misuse. We know that availability and access to substances like alcohol or prescription drugs within a community or regionally, but even also on the campus can be a huge risk factor for students that we need to be paying attention to. Things like socioeconomic status, those kind of social determinants of health can be large risk factors. Things like making sure that students can and have educational attainment, making sure that students have employment opportunities. Those are big risk factors that we need to be paying attention to. And finally, we need to think about sleep and nutrition and the role that that plays for our students in terms of effects that it can play on their physical, mental health, but also in terms of substance misuse. I'm going to share with you all a little bit of the data for West Virginia so we can examine that and really think about that in terms of our lens for some of our conversation. And I know some others are going to be sharing some of that information too later today. But if we really think about substance use and misuse, even nationally, the college age population is one of the highest groups that's at highest risk, and often their prevalence rates tend to be higher than some of the national average. So it's important for us to think about that and how we can help students. Every 2 years, West Virginia does the National College Health Assessment, which really gives us a nice snapshot of some of the prevalence rates for students. And if we look at that, we can look at how West Virginia students are often sometimes higher than the national rates. And I think that's something we as a state really need to start to focus on and work on developing some strategies and activities, just like Collegiate Recovery, to reach students and assist with them. And you're going to hear about some of those programs today, like Smart RX and some of those other things that are happening. If we look at prescription drug misuse in West Virginia, you can see if you look at the total numbers over here, West Virginia students are typically higher than the national rates. Particularly if you look at stimulant use, we have a much higher prevalence rate than the national numbers, and that's important for us to be focusing on. If we look at some of the other data from the NACHA survey, we look at some of the other types of substances that are often used or misused on college campuses, and those typically, alcohol is typically usually the #1, followed by marijuana, then followed by vaping and cigarette use. It's important when we look at data sometimes that we look at actual use versus the perception of use, because oftentimes society and our communities and students think sometimes that the actual use is much higher than the perception of the use is much higher than the actual use. So if we look over here at alcohol use, for example, 25%, almost 25% of our students have never used alcohol, yet only 5%, if we look at the perception, think that's the case. And so kind of dispelling some of those misperceptions and teaching students about the real information about their peers is really important strategy. You can see the same thing down here with marijuana use as well. It's important when we talk about substances and alcohol, since alcohol is usually #1 on campuses, that we talk about risky use. So anything that we kind of calculate this by 4 or more drinks is high risk for a female, and 5 or more for males is high use. And so if we look at this data for our West Virginia students, we can start to see here that students basically 40% of our males here are reporting that they had 7 or more drinks. And we know this data is really important because we know that this kind of behavior is really linked to very healthy or very negative complications like health outcomes, students failing, missing class, dropping out. We know that it's linked to blackouts. We know that it's also linked to alcohol poisoning. And so addressing some of these high numbers on campuses is really important for our students' overall health, but also for their success and making sure that they are successful in pursuing their degrees. I pulled a little bit of national data. This is the National Survey on Drug Use and Health, the NSDUH. This is a survey that's conducted by SAMHSA every year, and they do this via interview questions with over about 77,000 people around the nation. If we look at our data, you know, for West Virginia students in this 18 to 25 population, we're just slightly above, higher than the national when we look at their estimates on pain reliever misuse. But when we go down here and we look at heroin use in the past year, you can see that West Virginia in that 18 to 25 and even that 26 or older, they're reporting much higher rates, prevalence rates. And so that's really something that we need to be paying attention to, particularly those in higher ed and in our communities in our state in general. I also pulled just a little overdose data from our Office of Drug Control Policy. You know, everybody's been, you know, working really diligently and hard to reduce these numbers around the state and nationally. And from some of the data that I had seen early on, you know, many states were reporting reductions in 30 to 40% prior to COVID. But unfortunately, since COVID's hit, we've seen these rates kind of go back up again. And so it's really something that we need to be paying attention to and making sure that we're providing services and naloxone out there to individuals, education, helping them get connected to services. These are some of the demographic information. So 30 to 39 is our highest age group in West Virginia, but that's followed by that 20 to 29 age group. I shared this. This is the behavioral health continuum of care, and I look at this a lot when we're thinking about comprehensive plans to really work on services to address substance use disorder. And, you know, many campuses have worked over in this area. We've done a lot of health promotion. We've had wellness programs. We've done a lot of great work in that area. We've even done a lot of great work in prevention and making sure that we have evidence-based practices and programs. And, you know, many campuses have counseling centers and offer those kinds of programs, or they connect with local services in their community. But, you know, today we're going to be here to really talk about the importance of making sure that we have this recovery support and services on campuses, kind of the aftercare for students who may want to come back to campus, for students who are already on campus who may need this service as well. But this is really important in making sure that we're really providing that supportive space to them. I'm going to leave this last slide. These are some evidence-based practices and really prevention. These are the CSAP strategies. These are things that SAMHSA has really designated as some of the important things that we can do on campuses. And so those are things like environmental strategies, making sure that, you know, we have places for students to discard their prescription drugs, and things like making our campuses tobacco-free. Those are all environmental strategies that we can implement. Prevention education, those are things that share the harms and effects and risks of substances. And again, you can hear about some of those programs like SmartRx later on today that are really working on, you know, teaching individuals about stimulant misuse. Evidence-based practices, many campuses, again, these are some of the prevention evidence-based practices that we've worked really hard to implement in West Virginia, and things like screening. But there are also other many important practices, making sure that maybe your campus has a medical amnesty policy so students can reach out for assistance and help. Making sure that campuses have access to overdose prevention education, naloxone and Narcan. Providing supportive recovery programs, which is really why we're here today, designating space and resources and making sure they have access to peers on those campuses. And those are going to be really critical, I think, for us in the higher ed landscape. And I'm very excited to be here with all of you all today, and I'm very excited for us to be looking at this issue in West Virginia and really growing these services. So thank you all very much. I'd be remiss if I didn't thank, our Economic Alliance and Dr. Gilbert and DHHR, who I know are coming on next to talk about some of our funding that have really made this opportunity possible, and for all of Susie's work really to help guide this and grow this in West Virginia. So thank you all.
Hey, good morning, everybody. My name is Elizabeth Coffey. I am the State Opioid Response Project Director, which is otherwise known as SOR. I work for the Department of Health and Human Resources and the Bureau for Behavioral Health. I want to talk to you a little bit about the SOR grant. West Virginia received approximately $43 million per year for 4 years from SAMHSA for this grant. The first 2 years, the funds could only be used for supporting opioid use disorder prevention, treatment, and recovery. The following 2 years, of which we just started, we can add stimulant use disorder and vaping. And the purpose of SOR grant is really threefold. It is to reduce overdose deaths, to increase access to evidence-based treatment, and decrease unmet treatment needs. Regarding the collegiate recovery, we have set aside in those 4 years 2 initiatives. One is the West Virginia Collegiate Initiative to address high-risk alcohol, and that's $240,000. And in addition, the West Virginia Collegiate Recovery Network, of which we're super happy to be a part of, that is $1,608,000 and a little bit more than that. I want to talk about the SOR funds as it relates to why we're here today. SAMHSA released a document describing that the 10 fundamental components of recovery, they listed those, and one of which was peer support, which means that peer recovery is a best practice for treating an individual with an SUD. And that also includes medication, assisted treatment, or otherwise we're calling it medication for OUD now, and including behavioral interventions. And so we're trying to work as far as that goes with the college campuses to really encourage peer support activities, because peer supports are better at cultivating hope and the belief that recovery is possible rather than non-peer programs. Amy provided a lot of data regarding why it's important for us to target the university settings, so I won't go into that, but I will say that West Virginia's substance use is comparable to national statistics in nearly all categories. This includes opioids, heroin, stimulants, alcohol, marijuana, and other illicit drugs. And although the proportion affected is not a majority, there is still an unmet treatment need for treatment facilities with programs for youth and young adults. Amy went over the risk factors, so I won't go through that, but I will talk about collegiate peer recovery specialist services and what they can offer on the campus. These peers serve as a vital link in West Virginia's continuum of care, which Amy mentioned, the prevention, early intervention, treatment, and recovery. And I want to go a little bit in specifically about some of those initiatives that the SOR grant funds. For example, we fund harm reduction programs, and these programs are vital because they meet the individuals where they are, and they provide a vital link. They have peer recovery support services at the harm reduction programs, and they can serve as a link to treatment. It may not be the first time that they talk with someone. It might not be the second or the third time, but we know that planting a seed is important, and peer recovery support specialists are able to plant those seeds in that harm reduction program. We also have peers in quick response teams, and those are teams that follow up after an individual has an overdose. They follow up within 24 to 72 hours to check on how the person's doing, but also to provide a resource information, whether they want to provide linkage to treatment for families, to link them to support services as well. We provide funding for drug-free mom and babies programs, peers in the emergency departments, and as well as regional jails. And these are all in addition to the peers that we support at the college level campuses. The peers are really important because they establish relationships within the community. They identify recovery-friendly services, and the peers they have lived experiences which serve as a connection to individuals which need assistance. They provide hope that recovery is possible. Here in West Virginia, we support all pathways to care, and not one size fits all approach. It's personalized. And so the peers, they don't actually tell a person how to get into recovery. They just provide some different options. And we do encourage HIV and HCV testing, and we provide resources, whether it's mental health, substance use disorder treatment, employment, housing, etc. Most important, peers are a link as follow-up care. They have that connection, that continuing to serve as a mentor, or just to help when someone is in trouble, they can call that person and get assistance. We are so happy to be a part of the Collegiate Recovery Network and provide funding that is so vital to West Virginia. And we're happy to be a part of this conference today. Thanks.
Well, good morning, everybody. Okay, want to make sure I was unmuted. Can't tell you how many times I've made that mistake. I'm Rachel Thaxton. I am the Assistant Director for the West Virginia Office of Drug Control Policy, and I'm here to talk to you about how our office has supported collegiate recovery programs in the past. But first, I just want to say that I'm also a person in long-term recovery from a substance use disorder. I'm also a graduate from West Virginia University. So that is something that over the years in my recovery has given me much pride and has been a great confidence builder and has made me more employable. And because of those things, I found that it was maybe a little bit easier to sustain long-term recovery. I consider that to be a protective factor. And I consider myself very lucky that I was able to make that accomplishment long before I ever entered recovery. So as you can probably tell, when I got to the Office of Drug Control Policy in early April, well, I guess it was April 2019, I was thrilled when they asked me to oversee the grants for collegiate recovery programs. The West Virginia Department of Health and Human Resources, Office of Drug Control Policy, partnered with the Bureau for Behavioral Health to announce the first funding opportunity to implement collegiate recovery programs in 2018. As you can see there, the funding amount was $20,000, and that went to 5 different campuses in West Virginia. The purpose was to create recovery resources for adult students with substance use disorder in higher education environments. The mission of the Office of Drug Control Policy and the Bureau for Behavioral Health is to make sure that all citizens in West Virginia have access to services that are comprehensive, readily accessible or on demand, and tailored to meet individual, family, and community needs. This mission extends into the collegiate community to combat the high rate of substance use in colleges and universities that can create obstacles and barriers for students with substance use disorders who are pursuing higher education. As you all know, every institution of higher education is rich and unique in the experiences it has to offer. Usually, only a fraction of the resources are fully accessed by students, whether in recovery or not. However, it does appear that students in recovery take advantage of resources that other students often overlook. By working to provide access to helpful resources, encouraging new relationships, cultivating peer support services, which Elizabeth talked a little bit about, imparting life skills, and celebrating the pursuit of educational goals, every collegiate recovery effort can impact change in the college community. We believe that an effective collegiate recovery program works with people at any stage of recovery. Persons with active behavioral health issues, so people who are still struggling can be linked to care and given referrals, as well as persons in long-term recovery, which can include multiple pathways along with medication-assisted treatment. All of the collegiate recovery programs that are supported by the Office of Drug Control Policy are equipped to accommodate the target students that are impacted by substance use disorders and facilitate their recovery by providing program services like recovery and outreach events on and off campus, recovery support groups like 12-step meetings and SMART meetings, recovery-oriented activities on and off campus, things such as guided meditation, yoga, recovery rallies, awareness events, the use of substance-free gathering spaces, which we know is so important to provide safe space on college campuses, peer mentoring and dedicated staff, referral to community-based services and supports as needed. And there's one more service that has just recently become increasingly important, and that's the providing access to virtual recovery events and services. With the onset of COVID, as we all know, that has been a challenge, but I think that all of our collegiate recovery programs and the peers working within the Collegiate Recovery Network have really risen to the occasion and done an excellent job of providing virtual resources for college campuses and the students. In 2019, the funding was extended for 4 of the 5 original collegiate recovery programs. And then in 2020, the funding amount was increased, and the Office of Drug Control Policy, we made a decision to expand the capacity for collegiate recovery programs in West Virginia. With the creation and partnership of the West Virginia Collegiate Recovery Network under the direction of Susie Mullens, we knew this expansion would be beneficial for students and people in recovery all over the state of West Virginia. And with that partnership, there have been several great things, obviously. One thing that we've organized with Susie leading the way is doing virtual naloxone trainings. In the beginning of all this, we knew that there were peers in West Virginia who had access to naloxone, and we knew that people in West Virginia needed that naloxone, and it was just a matter of figuring out how we would get it into their hands. And then another great product of this partnership is obviously this conference and bringing everyone together to raise awareness and educate people on collegiate recovery programs and how important they can be for people in recovery and for college campuses to retain students. And one thing and I'll close with this, I don't want us to lose sight of what this is really all about. This is about saving lives in West Virginia. As you all probably know, West Virginia has the highest overdose rate in the nation. And with COVID-19, we know that overdoses have increased even more. So, this is all about linking people to resources so that they can sustain their long-term recovery, because we know that the other side of that, if we lose people to this, their chances of overdose are higher than most. So people in recovery are some of the brightest and most resourceful people that you'll ever meet. So let's help these people reach their full potential. And just want to thank everybody for having me on the call today. And let me talk about the Office of Drug Control Policy. And I think up next we have Tim, so I'll pass it to him now.
Perfect. Thanks so much, Rachel. And first, let me just thank everyone for putting this whole event together and gathering us all here. Even if it is virtually, it's a great event, and just really pleased to be able to join everyone. And thank you all who are tuning in from across the state and other parts of the country. It's it's just great to gather everyone to talk about collegiate recovery. So my name is Tim Rabolt. I use he, him pronouns, and I'm the executive director for the Association of Recovery in Higher Education, ARHE. I'm going to talk a little bit about just collegiate recovery in general, kind of the 101 stuff, as well as a little bit of history around collegiate recovery and ARHE, and kind of, what the landscape looks like a little bit right now and where we might be headed. The best piece I can kind of give as far as a snapshot, and it's a little bit of time that I have with you all, is just an insight into my own experience. So about 10 years ago, I was still in high school here in Wilmington, Delaware, where I'm currently residing. And that's where my recovery journey started. And I also want to acknowledge just the sheer privilege that I had based on my identity and my family and different aspects like that I did have access to treatment and I did have access to recovery support. And so I was really fortunate in that regard. And I got sober, in senior year, and I went down to school in Washington, D.C. at George Washington University. And honestly, I had no idea about collegiate recovery, and I chose D.C. because I knew there would be a lot of recovery meetings in a city compared to some of the other more local schools that I was considering that I didn't think would have as many meetings. And when I got down there, I wasn't met with hundreds of students in recovery like I thought I was going to be. And I realized now I was pretty naive to kind of think that. And, what happened was I, progressed into my first semester of freshman year, and it was around December where I had, about 8 months in recovery at that point. And it was the lowest point I'd ever been in my entire life. And I was suicidal. And what brought me out of that point was all the aspects that go into building a collegiate recovery program, like a lot of the benefits that we talk about and a lot of the points that Rachel just kind of brought up as well. And what happened from that point is the administration, intervened and helped. And what happened a couple months later was there was our first meeting of Students for Recovery. So it was different students in recovery on campus, and we kept meeting, and the administration provided, food for us and space for us to meet. And we turned into a student organization and received funding. And then it kind of grew into a program, and they carved out actual physical space on campus for us. It was the ground floor of a townhouse right in the middle of campus, and we called it the Serenity Shack. And students in recovery had 24/7 access to that space. We used that space for meetings, we used it for watch parties, we used it to do work, used it just to hang out. And so you saw these different components, right? The community building, the social aspects, the dedicated space, the staff support. I wasn't in a particularly favorable housing situation, so the administration helped and bypassed some different loopholes so that I could get into a lodging situation that was going to benefit me in my recovery at that time as a freshman. And all these different components kind of come together, and that's really what a collegiate recovery program is all about. You can kind of boil it down to, like the 3 S's around staff, students, and space. The students being the actual community of students in recovery, and the effort and initiative to build that community out so the students in recovery, very much like I was, actually feel a part of the campus instead of apart from. That feeling of isolation and not feeling like you're a part of the culture on campus it's tough. It's a big battle for a lot of students. The space piece is actual space dedicated to recovery, right? That where students know they have a safe space they can go to and have their meetings and have their different events and things like that. And then the staff support is we can't put this all on students. There has to be a administration and investment in order to support the students, move some of the mountains that they can't move, plan some of the events, different pieces like that. So this whole concept of collegiate recovery is not totally new, although it is still, overall pretty new within higher ed and within student affairs. The first kind of effort around collegiate recovery was in the late 1970s at Brown University. A couple of the programs that are pretty well developed today at Rutgers and Texas Tech, they've been around for over 30 years. And that first meeting that I mentioned at George Washington that we had in February 2012, there was about 14 member institutions of what is now ARHE, the Association of Recovery in Higher Education. Today, we have nearly 150 institutional members, quite a bit outside the country, in Canada and the UK, definitely some in West Virginia, and definitely spread, all throughout the country. The first kind of meeting that led to the growth and development of ARHE as an organization was only about 10 years ago. It was about April 15th, 2010 at the first Collegiate Recovery Conference down in Lubbock, Texas. What happened there was, there was a handful of different programs at that time, and the staff came together, realizing there was a need for an association to kind of band the different programs together, help grow the field, represent collegiate recovery staff who are working to support students. And that's what led to the growth of ARHE. Today, we're a pretty small nonprofit association, although we do have, the 150 institutional members. We plan virtual events. COVID has obviously led us to kind of transition some of the things that we're focusing on a bit more. So it's a lot of, virtual events just like this, and weekly webinars and blogs, and working with different committees, and really just trying to help the collegiate recovery field grow. So this event is a perfect kind of encapsulation of that. Just trying to check the time to make sure I don't go over and cover all the different pieces. The other piece I want to make sure we get to is just a bit about the research. So Sierra, who's up next, will talk about this a little bit more and touch on it, and maybe go in depth in some of the different aspects. But overall, the research is not exactly where we would want it to be in the field, but it's trending in a really great direction. One study in particular that kind of gets cited quite a bit in advocacy for collegiate recovery and a lot of these kind of conversations and events over time is the first national study that was done about 5 years ago by Dr. Alexander Lede. She surveyed about 500 students who were in recovery in collegiate recovery programs across about 30 different institutions throughout the country at that time. And there was kind of two key findings. There's a lot of interesting demographics if anyone wants to, go look at their reports further. We have a lot of information up on our website as well. If you go to collegiaterecovery.org, we also have a YouTube channel where we put all of our, webinars that we do each week. So you can kind of look at the Collegiate Recovery 101 webinar there, or some of the other stuff that might be more pertinent, or, specific spotlights on different schools. But anyways, with this study, the two kind of key findings that I always come back to, at least, that are, really make the case for collegiate recovery and why it's the right investment for a university or college to make. One being around student success. So when compared to the average students at the universities, the students who are in recovery in these collegiate recovery programs had significantly higher student success metrics. So that's talking about GPAs, retention rates, graduation rates. Another piece I always thought was interesting there is just how involved in service, community service, that the students in recovery in the CRPs are. So when you look at that and what that translates to, the students are more successful, they're staying in school, they're graduating at higher rates. And then I look at that with my own experience where, yeah, we created our program, we had that student organization, and we had dozens of students that participated. But in that same amount of time, that short amount of time that I was at George Washington down in DC, I saw dozens of students come, or, I met them at different points in their journeys at GW, and they left the school entirely. And it's just sad, right? It's sad to see that happen and know how close I was to that same point, if not worse, and know that I got the support I needed, and see dozens of other students that don't. And so it's not just numbers we're talking about, it's actual lives, right? Student lives that can be changed and saved and transformed through recovery support and through having a community on campus. The second piece from that study that I'll kind of wrap up with is the impact on the typical addiction life cycle. So students in recovery versus, the average individual who's in recovery, they drank, they use around the same age for the first time. But a student who's has the benefit of a collegiate recovery program and is in college, on average is going to treatment a whole lot earlier. And they're sustaining their recovery after treatment a whole lot earlier. And that difference is about 15 years. So again, it's a number, but you think about how many students we're really talking about. And 15 years, the difference between a student or an individual out there battling addiction, all the consequences as a result of that disease, versus being, you know, an engaged student, being a successful student, giving back to the community, going on to be employed, being an engaged alum. Those are the students we want to create, right? Within higher ed, within student affairs. And so understand that we can invest in a program on campus that's not just the right thing to do, but it's, you know, the right thing for the university. Like, it helps everyone. It's truly a win-win. So I always come back to that study just because I think it's really important to, you know, hone in on the benefits of that. And just I want to close by saying, you know, I really do think within higher ed and within student affairs, we're going to see a day where students identifying as in recovery from addiction are met with an adequate level of compassion, commitment, and support. It's not just the right thing to do for the student, but ultimately it's the right thing to do for the school. Thank you all again for being here today and allowing me to share a little bit of my insight. And with that, I will turn things over to Sierra.
Thank you so much, Tim. I am going to get my slides up for you. Great. And it looks like it is rolling. And can you see a full screen version of my slides at this time?
Looks like you're in presenter mode.
Great. I am, and I know exactly why it's doing that.
You may want to switch monitors if you have two monitors.
Thank you. There we go. How is that?
That looks good.
Perfect. All right. So thanks so much again for having me here today. I'm really excited to share about a little bit more about collegiate recovery with you all. So you've already heard a bit about collegiate recovery impacts from Tim and from our previous speakers, and you'll hear a bit more from Dr. Allison Smith after me as well. And what I'm going to focus on is kind of the economic impacts, both to campuses and to the broader communities. But first, let me introduce myself. So I'm Sierra Castedo de Martell. I am the president of the Association of Recovery and Higher Education Board. I spent about 5 years as the director of a collegiate recovery program at the University of Texas at Austin. And actually before that, I started out as a student in recovery myself. I started my collegiate recovery journey at that collegiate recovery program. And today I am a researcher at the University of Texas Health Science Center in Houston. I'm based in the Austin campus though. And my research focuses specifically on the economic impacts of different recovery infrastructure pieces like collegiate recovery programs and also workforce related issues. And so I am going to focus on that piece and talk a little bit about some of my research and the broader economic implications of collegiate recovery programs. But first, let's talk about costs. I think costs and safety are on a lot of people's minds right now, especially on college campuses. I also want to talk about the investment that collegiate recovery represents. Costs are particularly front of mind because of all the economic impacts of the COVID-19 pandemic. And, you know, every state has been hit. West Virginia definitely has been hit as well. And we're really feeling it in our college campuses. There's been some pretty substantial impacts to enrollment, especially at community colleges. And right now, it's more important than ever before to make sure that what we choose to invest our limited resources in makes good economic sense. And one of the ways that we figure out what makes good economic sense is through a method called cost effectiveness analysis. Now, I know it's early, you don't really want to look at a mathematical formula right now. I'm gonna only show this for a couple minutes and not dwell on the math part too long, don't worry. But what we want to look at in cost effectiveness analysis, we're trying to figure out how much money an intervention costs for every unit of benefit that it gives us. So for example, how much does a collegiate recovery program cost for every good year of life expectancy that it gives us back? Or if we're looking at the college campus lens, how much does this cost for every student that we get to retain in good economics or academic standing? Now we find that result by figuring out all the costs that go into running our collegiate recovery program. We subtract out the costs of doing nothing, you know, not having a collegiate recovery program. And then we divide that by the benefits that we get from having the collegiate recovery program versus not having the program, right? So to fill out that equation that I just showed you, we need to figure out what an average CRP looks like and what an average college campus looks like. Now, there's a good deal of research on collegiate recovery programs, like Tim alluded to. We definitely want to see that evidence base continue to grow, and we do have some gaps, but we have a pretty good idea of the kinds of benefits that students in these programs see. We know that these programs do a really fantastic job of keeping people in recovery. And 92% of students in these programs stay in sustained recovery while they're there. Only about 40 to 60% of people in kind of the general addiction recovery population are able to sustain recovery like that. We know that students in CRPs also have really great academic outcomes. They stay in school through graduation. They tend to have really great GPAs compared to kind of the average college student GPA. And we also need to think about how many students are participating on average and how much a program costs to run on average. Now, if you want to know more about, you know, what we know about collegiate recovery programs, I've included at the bottom here, I think you should be able to see my mouse, a great literature review that came out just a couple of years ago. After this presentation, I'll make sure to copy and paste that into the chat box too, so it's easier for you to look up. But I know, you know, we've got a lot of kind of academic-minded folks here and higher ed folks, so if you want to do a little bit more reading, there's a great summary of it at this literature review. So then we also want to take into account kind of that average college campus picture, and I've listed some of the factors we look at there. And then we also want to take into consideration the perspective of the society at large too, the larger society around us. And when I put all of that together, here's what I found. At an average CRP, at an average campus, collegiate recovery programs save society over $3,000 for every year of life they add. And they save campuses over $11,000 for every student that's retained. Now, I also ran a bunch of sensitivity analyses. So basically that tells me that if I were to, for example, increase or decrease the budget of the CRP, or if I was going to increase or decrease the retention rate, that would impact my cost effectiveness result in a bunch of different ways. And so it kind of gives me a picture of what the tolerances are, right? Under what conditions is the program cost effective or cost saving? And I have to tell you, it is a really broad range of variation. It only takes a few students, so a really small program, to be cost effective and cost saving. And larger programs will see even greater efficiency. So really there's a lot of variation that can be encompassed and still realize these great economic outputs. So these numbers, the specific numbers that I have listed up here, again, that's from kind of my analysis of an average CRP at an average campus. Now, I also took this model and I made it into a toolkit where you can actually get a cost effectiveness result for your own program, either as it currently exists or a program that you're proposing. And I made a tutorial on how to use the toolkit. And the tutorial, the toolkit itself, and some other supporting materials are all available on the ARHE website. If you go to collegiaterecovery.org/media, I'll also drop that link into the chat box after this presentation so it's easier for you to find. Now, the toolkit looks like a spreadsheet. It's got some yellow or blue cells where you're going to enter your own campus and CRP information, and it's going to give you a result. Generally, when you see a negative number as your result, that means it's cost saving overall. And a program can still be cost effective without being cost saving. You just determine what your threshold for cost effectiveness is. And I actually give some guidelines on how to do that and what you might want to compare it to at the link in those resources. So we've covered cost effectiveness and cost savings that can be realized from a collegiate recovery program year to year, the benefits that your students and your campus see while they're on your campus. But higher education is just the start of something great. It's just the jumping off point. It's really only the beginning. One thing that my cost effectiveness analysis does not capture is the fact that we're interrupting substance use disorder early in the life of a young person. We also might be interrupting early in the course of substance use disorder for a person who's not so young, for our non-traditional students. It's still early. Tim alluded to that recovery timeline, and that's what I'm going to jump into right now. So the image before you, it's the typical course of substance use disorder and recovery. And this timeline was developed by the Recovery Research Institute. It's part of Massachusetts General Hospital and Harvard Medical School. It was founded by recovery researcher Dr. John Kelly, and he and his team are really some of the foremost researchers on addiction recovery in the world. Great team. So let's walk through what the timeline looks like for the general population. We're seeing about 4 to 5 years between developing an addiction and seeking help for the first time. Earlier detection and earlier intervention can help shorten this gap between the start of addiction and seeking help. But we also know that for people who develop substance use disorders, you know, they start using in their teenage years typically. So we might be seeing that first attempt at help, you know, among our college students. If somebody started drinking at say 16 or using substances at 16, you know, they might be 20 and solidly in the middle of their academic career at that first instance of trying to seek help, right? So ideally, if we're screening for addiction in places like our campus health centers, we also might be able to jumpstart that help seeking process a little bit earlier. And there's other ways to do that too. I'm going to get into that a little bit more. Then it takes an average of 8 years, almost a decade, of cycling through multiple attempts at treatment, engaging and disengaging with mutual help organizations, and racking up all those devastating consequences of addiction before someone achieves that first year of recovery. And in that 8 years, all too often for too many people, treatment episodes look like 30 days, or if you're very lucky, 90 days of intensive help and support, and then being placed all too often back into the same or very similar environment with all of the temptations, triggers, and challenges that come along with that. So let's take that example we used earlier, somebody who started drinking at 16, they're seeking help for the first time at 20. And after treatment, they've successfully sought help. After treatment, they return back to campus. And let's say we're at a campus where there's no collegiate recovery program, where many of their peers are organizing social activities around drinking. And all too often, you know, our best prevention efforts, we know a lot of those really are successful, but with those low or moderate risk individuals. And they don't, unfortunately, help a lot for students who are in this high risk category, like this student who sought help successfully, but now needs to protect their recovery in this really challenging environment. So how is that student supposed to succeed? And so here we have another opportunity to interrupt with collegiate recovery. So again, I just want to point out though, once a person does reach that first year, their risk of returning to use drops, but it drops even more once they reach 5 years of sustained recovery. It drops below 15%, which is really fantastic. And at the end of the day, you know, even in the typical trajectory of substance use and recovery, even without these additional very successful interventions, still about 60% of individuals with addiction will find lifelong recovery, which is fantastic. This is great news. Most people will eventually find recovery. But why does it have to take so long? Why do we have to sacrifice the prime of somebody's life and let it be dominated by this absolutely devastating disease, right? So that's where we want to enter in and interrupt this cycle, right? So instead, if we have a hub of recovery on college campuses, we can shorten that 8 years of going in and out because we can protect that recovery after somebody has sought help and come back to campus and tried to continue on with their normative development, their normative experience of being in college. We can provide a place where they can learn how to be a person in recovery, learn how to be a college student in recovery, while they're also continuing their higher education to learn how to be an engineer or computer scientist or whatever else they want to become, right? And we can also cut down those 4 to 5 years of struggling before they ask for help. If recovery is visible and celebrated on campus, if there's a resource hub for somebody who is in that contemplation stage where they're just now beginning to think that they might have a problem with substances, if there's a place for them to see recovery as possible, to get the information that they need, to maybe talk to somebody or talk to a fellow student, that is a fantastic way to shorten that time to that first asking for help instance, right? So I also want to talk just a little bit, briefly touch on the fact that one of the most common challenges that we hear in the collegiate recovery field about the idea of collegiate recovery is, we don't have those students on our campus. I think most of the people, probably almost everybody in this room, knows that that's just not true. People with substance use disorders are everywhere already, whether you know it or not. And we know that's especially true with young people, college-age individuals. The prevalence of substance use disorder among the 18 to 25 age group is the highest of any age group. It's about 15%. And that number is not different between students in college and students not in college. So they're here, we must do our best to actually support those students and make it possible to get help. So collegiate recovery is key to interrupting that timeline of addiction, and addiction left to its own devices, it doesn't just rob that individual person of opportunity and of those prime years of their life. It also has ripple effects out into broader society as well, but so does recovery. And that's what I'm going to talk about next. So when we interrupt that timeline, what are all of the benefits that we get to see at the local and state and national level because of that recovery? So let's again start with the individual level. So it's not really any secret that college graduates have more opportunity, and especially for economic advancement, than people who don't graduate from college. And we can actually quantify that. The number is about $17,500 different. So college grads earn over $17,000 more per year than their non-college grad peers. And think about what a difference in earning power that means for your alumni base, for your community, for your state, if that is multiplied year after year over a lifetime. And it's not just earning power. Meaningful employment is also something that is a pillar of recovery as defined by the Substance Abuse and Mental Health Services Administration. Meaningful employment that brings a sense of purpose, that staves off financial insecurity. That's a really critical part of maintaining that recovery long term. And for a lot of people, not all, but a lot of people, finding that meaningful and purposeful employment might mean turning their hard-earned experience with addiction into an employment opportunity. Now, all the way back in 2005, there was a national study of the addiction workforce, and they found that about 50% of the addiction workforce was made up of people who are in recovery themselves. And we actually expect that number to be a lot higher by now because of the successful expansion of peer recovery support services and the peer workforce, including in West Virginia. One of the previous speakers alluded to that. Y'all have a really fantastic peer recovery support services program here, and many states have also done a great job of building up that workforce. So we think that number is probably a lot higher now, but we just don't have a good, evidence for that yet. But when you make it possible for people in recovery, for peers, to find careers, you're making a really tremendous stride for equity too. People in recovery have all sorts of obstacles in their path because of their addiction, and we know that this disproportionately affects different people based on a variety of different factors. Now, that might be an arrest record, that might be a spotty employment history, or having been fired from jobs. It also might be more relevant for the campus piece, bad grades on a transcript, or spotty transcripts where a person might have had to drop out and then re-enroll and so on. So explaining that, overcoming those obstacles can be really challenging. And collegiate recovery programs, because they specialize in this population and in this, preparing for that next stage in life, we're really well versed in helping people overcome those obstacles and navigate a path through, no matter what career they're going into. But for those that do choose to turn around and use that experience to help others, that's something that's really critically needed right now. The opioid crisis didn't go away because of the pandemic. And in fact, it got a lot worse. Surveillance always lacks a little bit behind what's actually happening. But what we do know is that in some areas, opioid overdose mortality, for example, opioid overdose deaths have increased by as much as 50% since the start of the pandemic. And now we need a lot of our people in recovery to sustain their recovery and to hopefully find a way to bolster that addiction workforce by finding their way into the field of addiction recovery. Because when they do that, they multiply their recovery. William White, who's kind of a historian and really kind of an elder figure in the recovery movement, he used the term recovery carriers. And I'll read this quote from him. Addiction is visible everywhere in this culture, but the transformative power of recovery is hidden behind closed doors. It is time we all became recovery carriers. And we need recovery carriers, people like you who can make space and give support to those carriers to multiply the benefits of recovery. To carry that message of recovery to that student asking for help for the first time all the way back in the campus clinic, to make sure that the student who's coming back to campus after finishing a treatment episode is supported and gets that chance to flourish in their recovery and in their higher education. And so here's where we are right now. Like I said, substance use disorder has only gotten worse during the pandemic, and that's at the same time that the existing infrastructure to treat people with addiction, to help people with addiction, it's been really hard hit by the pandemic. One survey of providers in California found that 2/3 of them have experienced moderate to large financial impacts from the pandemic. And right here in Austin, we lost our only safety net treatment provider because of the financial consequences of the pandemic. And we know that your campuses are also hurting financially right now. Enrollment is down across all campuses nationally by about 16% and about 22% at community colleges. So it's particularly hit community colleges very hard. So we have to face these dual crises head on. Right now, we need to invest in collegiate recovery programs because they are cost-effective and cost-saving solutions that help your campuses attract and retain students. They also hold the door open to opportunity and future employment across a wide variety of fields. I had students in every major, from social workers to engineers and research scientists. And because collegiate recovery programs are embedded in not just their campuses, but in their communities too, these ripple effects are going to be felt out in the broader community and out across the state and across the nation as well. So we must sustain these programs to realize the long-term benefits and not just stop at the year-to-year cost effectiveness or cost savings that we realize in the short term. And finally, we must allow that recovery to multiply across West Virginia, across the nation. You have already made such tremendous strides in your collegiate recovery expansion initiatives. And because of that, you are helping students in recovery find employment, pursue their higher education goals, and you're lowering the barriers to opportunity for a lifetime. So I want to thank all of you for having me here today and for letting me share alongside these fantastic colleagues. Please don't hesitate to get in touch if I can be of any assistance, and I'm going to drop those links that I mentioned into the chat box. Thank you so much for your time.
Great, thank you so much for all of that, Sierra and Tim and everyone who's spoken before me. I will jump right on into my slides. Okay, so today you've heard a lot about collegiate recovery, and throughout the rest of this day, you'll hear tons of different topics about different aspects of collegiate recovery. One of the things I want to talk to you about is being sure that we're building equitable, diverse, inclusive, reflective spaces of our growing and ever-changing student populations. And so I'll go ahead and introduce myself. I'm Allison Smith. I am the Senior Program Administrator for the Louisiana Board of Regents for the Louisiana Center Addressing Substance Use in Collegiate Communities, the LaHEC office, but you really don't have to remember any of those acronyms. A little bit about me. I'm from Baton Rouge, Louisiana, where I currently am. I'm the youngest of 7 children. I could live off a diet of hot wings and crawfish if it wouldn't kill me. I graduated from Southern University in 2009 with a bachelor's in psychology, which is in HBCU, which I'll mention in a little bit. I graduated in 2011 with a master's in public administration from Louisiana State University, and I went to school for the last time ever, and I finished at LSU again for my master's in higher education administration. Oh, a couple of more things. I'm still really upset about the ending of Game of Thrones and that Girlfriends never got a proper ending. So that's a little bit about me before we jump into story time. I got involved with collegiate recovery about 5 years ago when I was actually ready to walk away from the field of collegiate recovery, substance use prevention, and higher ed. Typically, it's not a very diverse space when you get particularly to the staff side of collegiate recovery. I met who I affectionately refer to as my collegiate fairy godmother, Eileen McRae. She invited me to the Southeastern Collegiate Recovery Summit. I had known going that weekend that I would be the only Black person there that weekend. And I was almost right. There ended up being one other Black person there, was a Black male who was a 50-ish non-traditional student in one of the collegiate recovery programs. The reason why I knew that I would be the only Black person there is because I had already researched every staff office for all of the collegiate recovery programs in the Southeastern Continent. That's typically something that a lot of Black people, particularly researching kind of what space you're walking into. Like I said, getting on this side of prevention and higher education tends to be much less diverse, particularly on the staff side. And I met Eileen McRae there. We had a great time. She invited me up to their treatment center to hang out for the weekend and kind of see how it works, how it functions. And I met an amazing guy there who's still one of the funniest people. And he's told me his story about his sobering moment, he called it. He told me about how he had hit rock bottom and that he just could not believe he thought his life was over. And he said, but that night when I flipped my car, I had a twofold amazement. One, the sheer power of his story of recovery and seeing what treatment and recovery did for him. And he is surviving and thriving right now, helping. But then also, I was sheerly surprised. I was like, that would not happen to a Black person. And it's funny because the other Black person on the trip that we came with me said the exact same thing. And it's that one, we have systemic issues in our society that also, they don't stop at the gate. Stop at the policies that we have systemic in this country. Our colleges are microcosms of those particular institutions and seeing how that function. And so when we have the opportunity to build programming, to make sure that we're addressing those inequities within who gets the second chance. I have a colleague of mine, she works in athletics and she does prevention counseling. We talk about that with athletes who have substance use and things of that sort. It's who gets the benefit of addiction. A lot of it's just, they decided to, athletes that, they just decided to use. Most people who have the opportunity, for those who are high performing, who have the opportunity to go on and make millions of dollars, typically we just dismiss them. Things I started to notice that particular conversation years before we moved to the Board of Regents was Tyrann Mathieu. who's affectionately known as the Honey Badger. He was dismissed from the LSU football team, and he kept failing multiple drug tests. They had taught some treatment help and things of that sort. But the conversation around Baton Rouge, the LSU community said he just won't stop smoking weed. It was never considered that he may have an actual problem. Everyone felt, a lot of the people in the community doing this, he's jeopardizing my chance to be a fan of a winning team. He just won't stop. He never explicitly said he was in recovery, but he talks about some of his videos, how when he went out to Arizona, how he got with some of his friends, really good friends, who helped him walk a different life, who he got himself together, as he likes to put it. Those kinds of things. That recovery is possible for them. There is tons of health equity disparities among Black and brown people and white people in our country. For instance, Black women are more likely to die, or 3 or 4 times more likely to die those health inequities play out in our system, particularly when we talk about things like Medicaid expansion, socioeconomic status, who has access to care. So a few years ago, I'm in Louisiana. Our governor, Edwards, he is a Democrat. He is the only Democrat of a Southern state, and it makes a very interesting politics for our state. So literally everything they do has to be bipartisan at some point. But one of the things that happened, one of the very first things that he did was he signed Medicaid expansion into law. And the biggest driver why our state was able to get bipartisan support behind that was because it included access to treatment, particularly for people in our hardest hit, mostly white rural communities that were able to get access to treatment. Once funding came out with the state opioid response grants and things of that sort that allowed access for treatment to fall to increase medication access and medication assisted treatment, things of those sorts, we saw a different type of support for Medicaid expansion in our.
Dr. Smith, I'm sorry to interrupt
back
you.
all the way to the crime bill, the 1994 crime bill. Go ahead, Susie.
Yes, we're having some technical issues. Your sound is cutting out and glitching, and I wonder if it's the graphics in the PowerPoint.
I can turn my video. I'll turn my video off while I present. It should help. 1 second.
Okay, thank you. I apologize for the interruption.
Oh, no problem. Hold on 1 second. Now, Susie?
Keep going.
Okay, perfect. I just want to be sure that you can hear me. Okay, one of those things back to the 1994 crime bill was that crack and cocaine were treated completely different. And the impact that were totally different to brown communities at a much higher rate, and they were not met with the compassion and care that we tend to see the opioid crisis being met with. And even when we talk about the opioid crisis, a lot of times nationally, when we look at it, we see it as an epidemic that largely affects white populations. But statistically, the epidemic is rising faster among Black communities. And so one of those things being big sure that as we build and as we reshape our policies, we're adjusting for those types of health equity. Again, I'm glad Tim mentioned it in his particular part of the presentation, where he said he knows it was a privilege to have access to treatment. Not everyone has access to treatment, and that becomes we talk about opening up to all types of recovery program, having gone to a treatment center, having done long-term care, they're practicing AA in that exact pattern, being open to diverse pathways for treatment. Another thing is I talked about some of the way that policies interact our plans and programs on our campuses. Some of those are structural issues. Some of these things are bigger than any one person on this call. They're bigger than your office. You don't write the policies for you. write the policies for our country, but there's a cost when you have a bad foundation. Favorite shows, I love Chip and Joanna Haynes. Gaines. One of the things is whenever there's a foundation issue or something, both of them hate having to call the buyer, the homeowner, like there's a cost. We have a new cost that's associated with that we found a foundation issue. The problem with foundation issues is nothing you build on top of a bad foundation will be stable. And so as we're talking, I know some of the campuses in West Virginia, you're looking to start collegiate recovery programs. You have the option, you're in the unique position where you get to build it right the first time. You get to construct properly. You get to make sure that your foundation, that your practices, your policies are equitable for every student that may walk through your door, and for the staff members that you'll be able to employ, the diverse staff members to reflect the student population. And if you've already have a collegiate recovery program on your campus and it has a foundation issue, I want to encourage you before you expand or lay or build another thing out to stop and repair your foundation first. Because although it may seem stable for a while, the higher up you go, the more unstable it becomes. So it's a good time to, and it may be a chance to connect with some of the other units or offices on your campus. Your diversity, equity, and inclusion office, what are some of their best practices they recommend for writing policies or practices, making sure that it's inclusive of everyone on your campus. It's getting close to lunchtime, and I love tomato basil soup. There's in this particular soup, there's tomato, there's basil, there's heavy cream, there's some onions, some different kinds of seasoning. But when we look at it, all we see is basically the tomato. The one thing that everybody can immediately tell looking at this is that it's tomato soup, because all in this particular dish, everything looks like the dominant ingredient in the dish. And so when we're talking about building equitable and diverse collegiate recovery communities, we want to make sure that we're not just asking everybody to drop their background, their ethnicity, their culture at the door and assimilate to what the dominant culture is. And so that we want something where everyone can be themselves and have a shared goal of these recovery while maintaining their own backgrounds. And so I mentioned I'm from Louisiana. And so for me, what that looks like is gumbo. And so this is, I'll play it there. So Louisiana seafood gumbo. In this particular pot, there is seafood, there's sausage, there's chicken, there's shrimp, there's a ton of different things. What's really good about gumbo is that there's distinct component with different flavor profiles. So you can eat a bowl of gumbo and everybody makes it different. I know that's what gumbo, but I hate okra. So where everything looks different, even though it's one dish, you can distinctly tell what every single thing in the dish is. And that's the multiculturalism that we're looking for, making sure that we build in something where everybody's is respected, is encouraged to be themselves and share in an amazing dish. And so being sure that we're building our collegiate that is equitable for everyone. And so lastly, I'll talk about the last thing I was talking about, Mike, was being intentional. One, we have to be programming that been like on its own. You will have to make sure that you're being intentional. You're not a diverse program. That's not what's evaluating your practices and policies. One, what does your practices and policies say? One of the things about practice and policy, when we talk about even just prevention on our campuses, a lot of us have things like bystander intervention. When you see something, say something. And one of the directions that comes with that is like typically is call the police. And all to think about how that reads differently, how that ground students and you're telling them to call the police, given the current racial and national climate that we're in. Would it be something as simple as if you see something, say something and call campus safety, or call for additional help, or call emergency services? The idea is the same, but it's the intentionality in the words that changes the way how that's heard for different students. And then another one would be review your recruitment strategy for students and staff. So
Allison, I think we might have completely lost your audio. Again, we apologize for the technical glitches. We're at the mercy of the internet these days. So we want to thank Dr. Smith and Sierra and Tim, Elizabeth, Rachel, Amy, and everyone for attending this session. If you have any questions for any of the presenters, please put those in the question and answer or in the chat. And I'll just remind you if you
Susie,
want.
I am back.
Are you back?
I
Okay.
am back, yes. Yes, my computer started shaking apparently. So yeah, I think my computer's messing up. But the very last part I'll share with you, I'll jump back to this last slide. One is being intentional about evaluating your practices and policies, reviewing your recruitment strategies for students and staff, and then also one, you can connect with me. I'll put my contact information up for anyone. I'll share my screen real quick for someone to, you can contact me to see my, we can follow up on any of these additional things. One, just being intentional, that I would encourage you all to be intentional about recruitment strategies, not just on the student side, but on the staff side as well. Okay, Susie, I will turn it back over to you.
Great, thank you. Well, this was a wonderful opening session, a wonderful keynote. What questions do folks have? I see we've got one in the question and answer. Sierra, do you have a recording of this great economic impact talk I can use at my university to make headway with getting this accomplished? That's a wonderful question. Sierra?
I don't have a recording of this specific talk, but I believe it was recorded and that recording will be distributed out to attendees, right? I'm not sure if that'll be in a format that you could download and just cut down, but you could certainly, you know, maybe make a recording off of that. And then let's see, the tutorial is available for sure. So I don't know if there's any components of that are helpful that you could pull out. Yeah.
So we are recording the sessions from today, and those will be made available. And on the collegiaterecovery.org website, Sierra's tutorial is available there. Do we have any other questions? Okay, well, we are going to play a short video as we close this session. Be sure and do the evaluation for this session. Each session you'll need to sign in and do the evaluation before and after. And I'm going to play this short video, and after the video we will take a break, and our next session starts at 12:30. I'm sorry, at 12:15. I scared everybody. So our next session will start at 12:15, and that is called Saving Lives and Creating Lifesavers. Creating lifesavers on campus and medication safety. And that will be with Mike Holmes from the Collegiate Recovery Network and Dr. Susan Bissett from the West Virginia Drug Intervention Institute. So bear with me here just a second. I'm going to share my screen and hopefully bring up this wonderful video. Well, perhaps I'm not. Allison, do you have the ability to share that?
Sure. Give me just one moment.
Great. And I want to give Allison a huge thanks for creating this video and everybody for submitting information and getting the slides together. This is a short highlight and overview of the Collegiate Recovery Network. So we're really excited about this and appreciate you, Allison, for putting this together. And again, thank you to everyone for coming to our session and to all the presenters. We really appreciate it. Hi, I'm Susie Mullens, and it is a privilege and highlight of my nearly 30-year career to serve as the coordinator for the West Virginia Collegiate Recovery Network, which is a project of the Alliance for the Economic Development of Southern West Virginia. The Alliance is comprised of 10 schools in Southern West Virginia. The schools listed in orange are part of Phase 1, and it is our goal to expand to the other 3 schools and beyond to fulfill the mission that every institution in West Virginia has an array of resources to build a robust recovery supportive campus. I'd like to take the opportunity with the rest of this presentation to showcase the schools and all the important work being done around our state.
My name's Annette Johnson, and I'm the Collegiate Recovery Coach at Bridge Valley Community and Technical College. I'm a person in long-term recovery, and I became interested in this position because I wish that I had somebody to guide me when I was in college and going through active addiction. I do my jobs because I hope that I can make an impact on a student's life. One of the things that I'm most proud of and proud to be a part of was Save a Life Naloxone Day. It was an initiative between Kanawha and Putnam County where we gave out over 1,000 kits of Narcan. We held a tent at the Bridge Valley campus in Montgomery where we distributed Narcan kits and gave the training to students and community members. The Collegiate Recovery Program, I believe, has made a big impact on the campus at Bridge Valley. I have done trainings with faculty and staff to help educate them and make our campus more recovery friendly.
West Virginia School of Osteopathic Medicine celebrated Recovery Month by releasing an anti-stigma campaign. The campaign was developed by Barb Holt, Dreamer Mace, and Misty Boggs in the WSOM SOR program and was funded by the WVCRN Bureau for Behavioral Health. The campaign consists of posters and e-book and soon become billboards across the state. The campaign brand is Ask Me, which stands for Anti-Stigma Campaign in Education. The layout and design was completed by TGG Consulting, and the beautiful photographs and stories were prepared by Mark Trent, nationally awarded photojournalist, and Nancy Adams, a professional writer. Each of the participants in the campaign was offered an opportunity for treatment during the 6-month interview process. Leanne has now been in recovery a few months, and Warren has talked with a peer recovery specialist about his options for treatment. PK, Michelle, and Jimmy have remained in active recovery. The ebook is available for viewing on our WVSOM CRCH website. This slide shows you where to find it on the website. The project was approved and supported by the WDHHR Bureau for Behavioral Health and the Communications Office. It was endorsed by Bob Hanson, West Virginia Office of Drug Control Policy, who contributed the preface of the book. If you would like posters to distribute in your area, please contact Barb Holt at 304-647-6204. Thank you.
Thanks again, everyone. We'll see you at the next session in just a few moments.
Okay, so we're going to end this session. If you are a participant, please use your confirmation email to rejoin for the next session. If you are a panelist for the next session, we apologize. This session went over a little bit, so we're going to close this out. Just use your same panelist link to rejoin, and we'll do the practice session for you guys in just a moment. The next session for participants will open at 12:15. Okay, thank you all.